Good morning. I just want to take this moment and let you know that you're really amongst a very lucky few who've chosen to be here, because this course is incredibly comprehensive and well designed by Dr. Sharma. And every single one of these things that you're going to see them on the boards. And as you saw the questions that Dr. Moreno put forth, I remember seeing them, and not much has changed since then. I remember seeing them when I took the boards 10 years ago, almost now, 8 years ago, and then 10 years before that. So I'll be looking forward to joining all of you in a couple of years to recertify once again in 2021. Okay, so contrast-induced nephropathy, we're going to have to change this now to contrast-associated nephropathy, Dr. Sharma, for next year's talk. These are my important disclosures. I have spent the last couple of decades really focusing on this, and I remember back in the Washington Hospital Center when I first left fellowship here, looking at the incidence of acute kidney injury and its impact on early and long-term outcome. And at that time, we had about an 18 to 20% rate of acute kidney injury. No one was paying attention to this, and we saw this very important association to mortality. It had been published, I think, the very first time by Peter McCullough in the American Journal of Medicine, the Green Journal. And since then, there's been so much progression in this area. And all you need to do is just know this talk, and you'll get all of the answers right on the acute kidney injury contrast association. First and foremost, the definition was always been about a 0.5 milligrams per deciliter increase or a 25% increase in baseline creatinine. That's how it's been defined in the past, but there's been a reorganization of how we should look at it across the board so everyone speaks the same language. And as a result, AKIN, which is the middle category here, is the one that I would say that you should all follow. And this is change from baseline increase of 0.3 milligrams, absolute increase of 0.3 milligrams per deciliter within 48 hours, or an increase of at least 1.5 to 2 times from baseline creatinine, or a renal output or a urine output of less than 0.5 milliliters per kilo per hour for more than 6 hours. So this is the nephrology from the association ASN that have put this AKIN criteria, and I think it's important. And they divide it into different stages of stage 1 when it's really, stage 0 when there's nothing, stage 1 when serum creatinine is 1.5 to 1 point times baseline, stage 2 to 3 times the baseline, and stage 3 is 3 times and above. So again, important to also look at the different levels of worsening renal function when you're looking at it. Why care about this? Because it's extremely relevant. It's associated with an increased hospital stay, increased resource utilization, increased costs, but very, very importantly, it's associated with morbidity and mortality. And you would imagine that that would be the most important thing, but the truth is that hospitals and healthcare systems care about the cost almost more than they care about the patient's lives. So it is actually extremely expensive. So this is very, very important. The association with mortality has been recognized for forever. And even with the new definition of being much more restricted, a 0.3 milligrams deciliter increase of absolute increase of the serum creatinine is pretty conservative way of saying that there has been some kidney damage. And if you actually look at this, the association, even with that level, to mortality is tremendous linear increase in mortality as you look at it, as you go from no AKI to stage 1 to stage 2 and 3, and you can see the association to these important heart clinical endpoints. I talked about the expense. It's really worse, not just about the hospital cost, the length of stay, the ward stay, ICU stay, but much more important is when there is renal replacement therapy or need for hemodialysis. And I think this is extremely important to think about this, because this could really, really, really impinge on the healthcare costs of the patients. This past month, exactly May 30th, online version of this is now available and went to print on May 30th and online, the New England Journal, Contrast-Associated Acute Kidney Injury, that I was honored to first author with Dr. Dangus and Dr. Weisbold, who is a nephrologist from University of Pennsylvania. So we try to look at this in a very, very holistic approach with real, true evidence of what's there. And so this is what this talk is. You're the first group to actually hear this talk, probably from the key article that just came out of the acute kidney injury. And I want to thank one of my dear fellows from Germany who helped me put these slides together, and I really appreciate all the work that you have done. The pathobiology of this important issue is extremely complex and multi-level, multifactorial. No one really knows what causes acute kidney injury, but we do know that there is direct tubular toxicity to the proximal tubules, such that there is acute kidney injury. You could see casts under the microscope. In the days that I was doing my residency, we would have to look under the microscope and do a renal sediment or urine sediment and look under the microscope. Those days are gone. But truly, there is an important renal casts that could be seen there. And then there is direct also afferent arteriolar vasoconstriction, direct effect of contrast media. There is reduced renal blood flow. So there is this and more apoptosis and loss of cells. So there is true injury, and some of it is permanent. And I think it's very, very important that the disturbance in the renal blood flow as a consequence of contrast media is something that is incredibly important, well documented, both in dog studies as well as in humans. So it is an important piece to understand it. How can we prevent contrast-associated acute kidney injury? And this was sort of the working of this review article that we just published on May 30th in the New England Journal. So we divided it into these three areas, and I'll go through that. First and foremost is really evaluating a patient's risk. And in my mind, every patient is at risk if you don't actually question and think about the consequences of contrast media injection, which is the basis of what it is that we are doing for our patients. So you need to determine that risk of acute kidney injury. And by that, I mean you have to assess their baseline risk. How can you do that? It's an important one, and we've made it easy. Not just me, but many, many other people. The baseline risk assessment has been one of the most important areas to see who is that patient who's at risk. But then beyond that, you have to even think above and beyond. The patient that has absolutely no risk, you as the physician have an important factor, modifiable risk, that you could be in charge of, meaning the volume of the contrast media and how you're reacting in the cath lab. So those high-risk patients and these risk scores, I was the first to put out a risk score, the Moran risk score. We are in the process of recalibrating that risk score with Dr. Davide Cao and some of my fellows who are working very, very closely on this project. This recalibration is the reason why we need to go back and see, are there other new risk factors, because this risk score was published and evaluated on the old data with the old definitions, and we need to relook at it. But since then, there's been literally 10 risk scores. I still would say that the risk score that we originally came up with and published, I believe was in 2004, is still very, very viable, has a really good C statistic, even with the old criteria. I think we can enhance and improve it now, and we're working on that. But it is important when you think about who is that high-risk patient, is to think about a kidney that is already had been damaged. A patient with chronic kidney disease and diabetes is the biggest flag that you must be thinking about. And if you say, well, the creatinine is 1, and so the patient doesn't have chronic kidney disease, you're mistaken. You've got to measure the renal function using, at the very least, the estimated glomerular filtration rate, the eGFR. Hemodynamic instability is another one. STEMI patients in whom we don't know what their baseline creatinine is because we're moving straight into the lab. But when you have a diabetic patient who's hemodynamically unstable and is having a STEMI, that patient, you might save their heart, but you might lose their kidneys if you're not careful, if you're not hydrating, if you're not working hard and thinking about the kidneys when you're treating their heart issues. And then, of course, there are very, very important modifiable risks that should be evaluated. The little old lady whose creatinine is 0.9 or 1, but then you measure their estimated GFR to be 40 cc's per minute because she's frail and elderly. And then, by the way, she has so much rheumatoid arthritis or osteoarthritis that at home she's taking daily non-steroidal anti-inflammatory drugs. If you didn't take that history and you didn't assess that, then you missed a very big opportunity in understanding that this woman should get very little to no contrast. She should be hydrated. She should come in the night before, and we should be very, very careful with good planning on how we're going to do her intervention or her diagnostic cath even. So this is the Moran risk score. This is a very simple risk calculator. We're in the process of improving, enhancing, and recalibrating this and having it be available on an app, both this particular risk score and the newly defined clean one. But take a look at all of these important risk stratification variables. The one that we selected, the Moran risk score published in 2004, is amongst some of the post-procedural risk stratification. And the reason for that is that you could, it was the amount of contrast, the volume of the contrast for every 100 cc's, you got a single digit, an integer score. So if you gave 200 cc's, so the pre-procedural risk stratification is important, and GERM has done this from the Michigan insurance databases, but I think it is important to note that these are all really good risk stratifications. Something should be used to assess the risk of the patients. I can't underestimate the status of the kidneys when you are evaluating the patient. Underlying chronic kidney disease is one of the most important, powerful predictors of acute kidney injury after contrast media injection. And the risk increases with declining estimated GFR. If you look at the National Cardiovascular, the NCDR, if you look at the rate of AKI, it's really a linear relationship going up, and Tom Tsai showed this in one of his most recent evaluations in 2014, showing a linear relationship in relation to the degree of chronic kidney disease. Also, the contrast media and the contrast type matter. So here's what we need to do. You need to use low or isoosmolar contrast media, minimize the contrast volume, suspend the nephrotoxic medications, and administer hydration, preferably and possibly, if you can, with isotonic sodium chloride. What evidence do we have for this? And this was our recommendation in our publication. Actually, there is a Class 1A recommendation in our guidelines for the use of isoosmolar or low osmolar equally contrast media for the procedures, and we should never go above 350 cc's of dye in any patient. You have to minimize your dye injection. So high osmolar, high PEG, you have never seen it because it's really out. this was a really truly nephrotoxic agent, and in the early days we used to use this particular high osmolar compound. Minimizing the contrast volume is another one. Very, very important, good evidence showing that there is a linear relationship. The higher the volume, the more contrast media, especially when the risk of a patient is high. So the reason for this, there's been some pathobiological studies that have been done, and a lot of it has to do that you have a higher concentration in the tubules, and of course, if you have a low GFR, that concentration doubles almost with every time there's low GFR. And then, of course, if you have a dehydrated state such that there is less glomerular filtrate, you're really going to have even a higher risk. So the volume has to be considered to be minimized, and we call that a 2A in our recommendations in the guidelines, in the PCI guidelines that I had the pleasure of co-authoring in 2011, and now we are looking at the revascularization guidelines, which should come out in 2020, and I'm taking part in that as well. And you can be sure that the recommendation of the contrast volume is going to remain there. Remember, these are always on the boards. The class recommendations are always on the boards. You should know these are important ones. Contrast volume, though, cannot be evaluated as a risk if it's never measured. And so in all of the NCDR reporting and all of the quality metrics that everyone is being measured at, and when you go into your practice, your volume will be measured. How much volume of contrast you're using will be measured. It's a modifiable risk factor. You should know how much volume you've given. You should be aware of it from the beginning to the middle to the end of the case. And you cannot modify, as I said, what you did not measure. And there is an interesting way of using renal function and coming up with a good dose-space ratio. And if you kind of use this ratio, you can be sure that there is a very important correlation, and there is like a place where this contrast nephropathy just takes off, and this ratio is somewhere between 2.6 and 3, where you start to see it take off. And so this is again a threshold of what should be used in important studies that have been done. Dr. Gurm also has looked at some of these sub-studies looking at underlying risk, the association of the contrast volume, and I think these are also very, very important. And others have also shown very important correlation back and forth. And of course, in our risk score, we use the integer score. You get for every 100 cc's, you get an important additional risk factor. So there are some practical approaches that can be used in the cath lab. You can use a GFR-based dosing. You monitor that volume at all cases. Routine feedback to the cath lab personnel. This is something we do in our lab. In high-risk patients, you avoid LV-gram. You use more intravascular imaging, and I'll show you some of that. And then, of course, you could consider some of these techniques and devices that actually take away some of the contrast media and not really, 30% reduction in contrast use. And that's the divert system that was studied in the AVERT study, and I'll show you that. And staging the procedures, but not staging them 2 days from now when the kidney is at its most vulnerable time, actually staging at least 2 weeks to a month in between procedures is also very, very important. So let's talk about minimizing contrast volume and what data do we have available. The Mozart randomized study is the one randomized study with 83 patients using angio versus IVUS guided, and they looked at the primary endpoint of volume of contrast, obviously. and 120-day MACE rates. And if you look at this, and I'm sorry if this is not coming across good, but the total volume of the contrast media is significantly reduced, as is the volume per each stent deployed, and even in relation to the contrast to creatinine clearance ratio, which is an important one, was significantly reduced when you used IVUS guidance. So these parameters could be important predictors in reducing acute kidney injury. There are also these other systems that can be used using a pressure sensor that evaluates when you inject, and a reservoir that once you inject and the coronaries are filled, the rest of the volume that you've injected, you'd be surprised, with every injection, with a manual injection, you're putting in at least 30% of the dye you actually do not need to visualize the coronary arteries. So we're always, with each injection, giving too much. So this particular system was used in this large prospective study, which we published in JACC Interventions last year, looking at 578 patients of control versus treatment to see if we could use this system with the contrast modulator, the reservoir that takes away the unused contrast. And what we did show, unfortunately, we weren't powered to show a reduction in contrast-induced acute kidney injury with only 578 patients, but we did show a 30% reduction in contrast volume use without any change in the imaging or ability to see the vessels. So there is very, very big hope. Hopefully we can do a very large study to figure this out. The CIN was really not changed at all, unfortunately, because we did not have an important, the highest risk patients did have a benefit, but I don't think once you have a negative study, these are all hypothesis generating. But very, very important, the one thing that actually really, really works is hydration. If we don't use hydration and are lazy and want to get done and just want to have that patient with chronic kidney disease and diabetes as the first case of the day and get out of the lab, then we're doing a big disservice to these patients. So what does hydration actually do, and how does it help in the pathobiology of what's going on in the kidneys when contrast media are injected? First and foremost, by using hydration, increasing the volume, the intravascular volume, you increase GFR and decrease the contrast concentration in the filtrate. That's number one. You also have a very, very important effect on decreasing oxidative stress and endogenous vasoconstrictors with hydration. It is actually the only thing that really, really works. All of these other studies, every single one, and I can name you aminophylline, L-DOPA, low-dose dopamine, all kinds of things that have been used, none of them work. So in contrast-induced acute kidney injury, the only thing that works is assessing the risk. And we have to know just three things. Assess the risk. Imagine that high-risk patient. Be very careful. Hydrate all of them. Hydration is key, and minimize contrast volume. And it doesn't matter which one of the contrast media, even though there's 50 studies that shows my contrast is better than your contrast, none of them matter as long in isoosmolar or low osmolar does not make a difference. So important to note that. But when you're hydrating, what should you use? And there's been several studies on sodium bicarbonate that showed, oh, this is a great study. Which one is it? What about N-acetylcysteine? Even in this hospital, we're still using N-acetylcysteine. I tell Dr. Sharma, you're treating yourself. You're not treating the patient. This is doing absolutely nothing. And many, many studies have been shown that it doesn't work. N-acetylcysteine doesn't work. But let me go through yet another study, the very, very important equipoise between N-acetylcysteine and sodium bicarbonate, led Dr. Stephen Weisbord, who's my co-author, to this very, very important study, which was published last year in the New England Journal. This was the PRESERVE trial, and it was very, very important with a 2x2 factorial, well-designed study. They looked at a very important endpoint of mortality, dialysis, or permanent renal damage, which meant a persistent increase in serum creatinine greater than 50% over 90 days, with secondary endpoints of just a little bit of an increase, etc. They randomized 5,177 patients with a very important interim analysis that they did. This was a 2x2 factorial design, N-acetylcysteine versus placebo, bicarbonate versus sodium chloride. And guess what? The primary endpoint was completely negative, but so was every single secondary endpoint. So neither one, sodium bicarbonate and N-acetylcysteine, work. By the way, you should know that the first N-acetylcysteine miracle drug data was based on 81 patients in the New England Journal of Medicine by Teppel, and there was a huge reduction. And when something is too good to be true, it's too good to be true. This is the definitive study in a 2x2 factorial design versus placebo. And others have shown that already, that it doesn't work. So the conclusion was that sodium bicarbonate is not more effective than sodium chloride in reducing acute kidney injury. And N-acetylcysteine is not effective versus placebo in the same. And so very important is to understand that the current standard of care of what we had suggested back in 2011 remains that you don't need to use N-acetylcysteine. In fact, it's 3, meaning not harm but no benefit. And isotonic, normal saline, when you can use it, is the way to go with the hydration. But then you might say, well, how do I guide the hydration? How much is too much? I don't want to put the patient into florid pulmonary edema. And so this study by my dear friend and colleague, one of our old fellows, who's now chief of the systems of the Kaiser Permanente Cardiovascular in California, Somjit Brar, published this paper. The Poseidon data is very, very interesting. He used an LV end diastolic pressure to gauge his hydration methodology. If the LV EDP, when he went in, before he did anything, he put the catheter into the LV, not a big deal, we do this all the time. Most fellows get into the LV before they get into the coronary when they're trying to get into the coronary, so that's an easy thing. Get into the LV EDP, get that. If the LV EDP is less than 13, he gave 5 mils per kilo per hour. If it was between 13 to 18, he gave 3. If it was greater than 18, he gave 1.5. And just based on that, thank you, Dr. Sharma, you just shut me off. Now I can't see my slides. He showed a very important reduction in acute kidney injury using this gauging of your of the 180 days outcome. So there was another study called the Amazing study. This was also a hydration group versus no hydration group. And this was a very large study published in the Lancet. And the Amazing study was not so amazing, actually showed no benefit in hydration to protecting the system. And you can see here that in the total population, it was completely negative. It did make it to the Lancet, but the reason why it didn't make it to the New England Journal, and I promise I wasn't one of the reviewers, was because of the important limitations. First and foremost, this is the only study in a single center with only 16% interventional procedures, with a very, very low event rate. This really was not 2.6%. They would need about 20,000 patients to show the effect of hydration in this healthy patient population. And then importantly, they didn't ascertain the CIN events carefully. Obviously, very, very important to note that although it's an amazing study, in the Lancet, it's not so amazing. So I still would hydrate as I have already given you. Don't use that study to guide you in the wrong direction. And last but not least is to perform an assessment of the kidney function. Often we get the patients up and out with ambulatory procedures. We don't see them again. And the event of acute kidney injury, where the kidney is most vulnerable from day 2 to day 7, is never, ever evaluated. And so it's really important that we should check, ideally, we should check all of the serum creatinines. If they're going up, we should keep them and hydrate them more. And repeat that measure in 24 to 72 hours. If they can't take oral hydration, you really should keep them in to give them IV hydration. What's coming down the future? There are several interesting technologies that are currently being tested. Mount Sinai was one of the highest enrollers in the renal guard, high urine flow, where their hydration followed by diuretic therapy was used to put this high renal flow state, urinary flow state possible and put in. I'm talking about 700 cc's out per hour, large volumes. We're going to show these data hopefully very, very soon. The pilot studies looked very good, both Mythos and the US pilot study. They showed really big reductions, but when it's too good to be true, it might not be. So we're going to see the US study. So finally, I just want to kind of have you take home messages. I told you 3 things to remember: assessing the risk of the patient, making sure that you gauge the volume of your contrast media, but most importantly is hydrating, preferably with sodium chloride if you can. These are crucial steps. This is a common condition, about 7 to 10%. It used to be 20%. I feel very, very good about the last 2 decades working very, very hard in this area. But I think by giving recognition and understanding this is an issue, we've reduced the rates of CIN from what used to be about 20% down to under 10% now. And I think it's a very, very important way to measure and understand what quality work you're doing in these patient populations. So thank you so much for your attention.